Good morning. In this video, we will be discussing about various acid-base disorders. The normal blood pH is between 7.38 to 7.42. If it goes less than this, we call it as acidosis, and if it crosses above 7.42, we call it as alkalosis. First, we will see about acidosis. Normally, the blood pH can be easily calculated using Henderson-Hasselbalch equation, which is nothing but pH is equal to pKa plus log of base by acid. In our blood, the major base present is bicarbonate, whereas the major acid present is carbonic acid. So, this equation can be rewritten like this: log of bicarbonate by carbonic acid. In this, carbonic acid is nothing but dissolved part of carbon dioxide. When carbon dioxide dissolves in water in the plasma, it reacts with water to form carbonic acid. Okay, so normally around 3% of carbon dioxide will be in the dissolved form to form carbonic acid. So this equation can be further rewritten as, instead of carbonic acid, it can be written as PCO2 into 3%, that means 0.003. From this equation, we can easily make out when acidosis can happen. Acidosis means decreased pH. So this pH can decrease either when the numerator bicarbonate decreases in the blood or the denominator PCO2 increases in the blood. It leads to acidosis or decreased pH. If this acidosis or decreased pH is due to decreased bicarbonate concentration, then it is called as metabolic acidosis. Whereas if the same acidosis is due to increased PCO2, then we call it as respiratory acidosis. So these are the two types of acidosis. One is metabolic acidosis, which is due to the defect in kidney renal regulation, whereas respiratory acidosis, which is due to the defect in pulmonary regulation. Next, with the same equation, we can also detect when alkalosis can happen. Alkalosis is nothing but increased pH. So this increased pH can happen whenever the numerator bicarbonate level increases or the denominator PCO2 decreases. If the alkalosis is due to excess bicarbonate in the blood, then it is called as metabolic alkalosis. On the same time, if it is due to decreased PCO2, then it is called as respiratory alkalosis. So these are the four major acid-base disorders: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. So these four disorders, usually they can present as two different types. One is simple disorder and the other one is mixed disorder. In simple disorder, any one component will be affected. Either the respiratory component or the metabolic component will be affected. Whereas in mixed disorder, it will be a combination of both respiratory and renal, both regulation will be affected. So it will be presenting with a mixed type of disorder. When it presents with a simple disorder, that means when only one component is affected, the other component, which is fine, which is working fine, they can overwork. Okay, they can compensate for this one, and they usually present with the compensation. Okay, the other component will try to compensate for the defective component. Okay, so how it compensates, I will explain you with a few explanation. Okay, so to start with, let us assume that a patient is suffering from respiratory acidosis. Okay, so what is respiratory acidosis? If it is caused due to excess accumulation of carbon dioxide. Okay, so which will happen during hypoventilation. Okay, so when breathing is not proper due to some reasons, PCO2, carbon dioxide, will be accumulating in the blood, which dissolves in water to form carbonic acid, and it can lead to respiratory acidosis. Okay, so when this respiratory acidosis happens, that means when the lungs fails, when the regulation, pulmonary regulation fails, kidney will try to compensate for it. Okay, so how kidney will try to compensate means, so as there is acidosis in the blood, kidney will try to remove the acids from the body. It will try to increase the excretion of acids. On the other hand, it also increases the base level. Okay, the bicarbonate level will be increased. Okay, so this what will happen means, artificially it produces metabolic alkalosis and results in the compensation, or they will try to bring down the pH to the normal. This is called as compensation. Okay, so in primary respiratory acidosis disorders, patient will also be having features of metabolic alkalosis, which has occurred due to for the purpose of compensation. Okay, on the other hand, suppose if a patient is having respiratory alkalosis, okay, so in such case, body will produce metabolic acidosis. Okay, so body will try to decrease the bicarbonate level in the blood. Okay, the base will be decreased and the acid excretion will also be decreased. So ultimately it compensates with metabolic acidosis. Okay, so respiratory alkalosis means pH will try to increase. Okay, so body will try to produce compensate it with metabolic acidosis so that the pH comes back to normal. Okay, so next, coming to the metabolic component. Suppose if the kidney regulation fails and there is excess, the kidney couldn't excrete the organic acid, or it couldn't reabsorb or generate the bicarbonate level, what will happen? Metabolic acidosis will happen. This will be mainly characterized by decreased bicarbonate levels. Okay, so under such conditions, lungs will come for the action, for the compensation. So how lungs will compensate means, so during acidosis, when acidosis is there, what will happen when acids are more? So these are acids. Okay, they will be not these acids. Actually, lungs will try to remove the carbonic acid so that the PCO2 level decreases, and that in turn will try to increase the pH by producing artificially respiratory alkalosis. Okay, so whenever metabolic acidosis is there, as a compensation, the patient will also be having features of respiratory alkalosis. Okay, next, coming to metabolic alkalosis, this will be compensated by respiratory acidosis. So this is how compensation works. Okay, so in a simple acid-base disorder, when only one component is affected, the other component will try to compensate for it. Okay, so when lungs are affected, kidney will try to compensate, whereas when kidney is affected, lungs will try to compensate. Okay, so this is how compensation happens. Now we will move on to the individual disorders. Okay, it's about the cause for each and individual disorders. First, we'll start with metabolic acidosis. What is metabolic acidosis? Acidosis happening due to the failure of renal regulation. Okay, so what is the role of kidney in acid-base regulation? It has two primary roles. One is to excrete the non-volatile acids. Second is to increase the bicarbonate levels. Okay, so if this is not done, when the reverse happens, that means whenever there is a loss of bicarbonate from the body, or when there is excess accumulation of organic acid, it leads to metabolic acidosis. Okay, so this is the two primary reasons for metabolic acidosis. Okay, next, coming to the causes for metabolic acidosis, it can be broadly classified into two types. One is high anion gap metabolic acidosis, and next is normal anion gap metabolic acidosis. To understand about this, first you should know what is anion gap. So what is anion gap means? Normally in our body, the total number of cations will always be equal to total number of anions. That is the nature. By nature, number of cations will always be equal to number of anions. But the measured cations, sodium and potassium, will never be equal to the measured anions, chloride and bicarbonate. Okay, so why they are not same, why they are not equal, why there is a gap means that is due to some unmeasured anions like proteins, phosphates and organic acids. Okay, so these unmeasured anions, proteins, phosphates and organic acids, together they constitute the anion gap. Okay, so now one of the important component of this anion gap is organic acid. Okay, so if I initially only I said metabolic acidosis can happen because of either due to loss of bicarbonate or due to increased organic acid. If it is due to increased organic acid, which is actually a component of anion gap, if it increases, the anion gap will also increase. Okay, so such type of disorder is called as high anion gap metabolic acidosis. On the other hand, if the metabolic acidosis happens due to loss of bicarbonate, it will not affect the anion gap. So that is called as normal anion gap metabolic acidosis. Okay, so metabolic acidosis can be broadly classified into two types by measuring the anion gap. Okay, so how to measure the anion gap means it is very simple. It can be easily calculated using the formula sum of the measured cations, sodium plus potassium, minus sum of the measured anions, chloride plus bicarbonate. Okay, so when you calculate this, you will be getting anion gap. Okay, so that value is nothing but that value corresponds these components, which are actually the unmeasured anions. Okay, so normally these unmeasured anions will be between 12 to 16 millimoles per liter. That is a normal anion gap. Suppose if it is more than that, then we call it as high anion gap metabolic acidosis. If it is within normal range, then we can call it as normal anion gap metabolic acidosis. Okay, so now we will see the cause causes for each one of this. First, we'll start with high anion gap metabolic acidosis. Okay, so as I already mentioned, high anion gap means it is due to excess organic acid accumulation in the blood. So this organic acid accumulation can happen because of two reasons. One is decreased excretion and the other one is increased production. So both can lead to accumulation of organic acid and high anion gap metabolic acidosis. Okay, so first let us see what is the reason for decreased excretion. So one of the main function of kidney is to excrete all these non-volatile or organic acid. So in renal failure, these acids cannot be excreted, so that they will be accumulating and leading to a metabolic acidosis. Okay. On the other hand, production of organic acids can be increased in the following conditions. To start with, ketoacidosis. Okay, so the production of keto acids, acetoacetic acid, beta hydroxy butyric acid. So all these keto acids production will be increased in diabetes mellitus, starvation, and also in alcoholism. Okay, so these are some of the reasons for excess organic acid production, which cannot be cleared off by the kidney, so that it can lead to high anion gap acidosis. Okay, so apart from keto acid accumulation, even lactic acid accumulation can also lead to the same type of metabolic acidosis. Then in salicylate poisoning, so when you take salicylate acid, so salicylic acid, when it gets metabolized in our body, it will be converted to oxalic acid. So this accumulation of oxalic acid can again lead to high anion gap metabolic acidosis. Next, methanol. Methanol we all know, by when you take methanol, that will be metabolized in our body to form formaldehyde, which ultimately will be converted to formic acid, and that can also lead to acidosis. And also ethylene glycol poisoning. Okay, ethylene glycol is an antifreeze agent. So now when you by accidentally, if you take if you have taken this poison, this will get metabolized in our body, and they will be producing a lot of oxalic acid, and that can also lead to high anion gap acidosis. And finally, we can also see this metabolic acidosis in patients suffering from amino aciduриas and other organic aciduриas. Okay, so that's it about the various causes for high anion gap metabolic acidosis. Okay, so when you think about high anion gap metabolic acidosis, means it is only due to the excess accumulation of organic acids in our body. Okay, so when this organic acid will accumulate, if it is not cleared by the kidney, or if the production increases. Okay, so for all these things we have already discussed the causes. Next, we'll move on to the second type of metabolic acidosis, which is nothing but normal anion gap acidosis. Okay, so here the acidosis is it is not due to excess accumulation of acid. Instead, it is due to loss of base. Okay, loss of bicarbonate. Okay, so whenever bicarbonate is lost from our body, for every bicarbonate lost, one chloride will be retained in excess. Okay, so this type of normal anion gap metabolic acidosis is also called as hyperchlorimic metabolic acidosis, because for loss of bicarbonate, one chloride will be taken up. Okay, that's the reason there is no change in the anion gap. Okay, so now we will see the causes for this bicarbonate loss. So this loss of bicarbonate can happen through two routes. One is through GIT and the other one is through kidney. So first we will see when it can be lost through GIT. Okay, so when you see the entire GIT, the upper half is highly acidic. Okay, whereas the lower half is mainly alkaline. Okay, so why the lower half is alkaline? Because of the excess bicarbonate production. Okay, so what will happen means this bicarbonate will be lost from the body from the lower GI disorders like diarrhea, pancreatic or intestinal fistula, and in patients who have underwent ureterosigmoidostomy procedure. Okay, so what is this ureterosigmoidostomy procedure means? It is a surgical procedure which is usually done in patients with bladder carcinoma. Okay, so whenever there is obstruction in the urinary bladder, so the ureter will be disconnected from the bladder and it will be converted to the sigmoid colon, so that the urine will be excreted through the anal canal. So that is the procedure done. Okay, so now in this condition, what will happen means, when the urine goes to the sigmoid colon, so the excess chloride content of the urine will be reabsorbed by the sigmoid colon. So when it reabsorbs chloride, for every chloride taken in, one bicarbonate will be lost, leading to bicarbonate loss from the intestine. Okay, so these are the causes for loss of bicarbonate through GIT. Alternatively, it can also be lost from the kidney. So in kidney, how it can be lost means, normally kidney, the almost 100% of the bicarbonate will be reabsorbed by the renal tubules in the proximal convoluted tubule. For this reabsorption, we need two proteins. One is sodium H plus antipode, which is present in the tubular epithelial cells. Okay, so that is the one which will take up sodium, it will reabsorb sodium and will throw out H plus ions. Okay, so that H plus ions will bind with the bicarbonate and they will be helping in the reabsorption of bicarbonate, filtered bicarbonate. Okay, so when this sodium H plus transporter is defective, bicarbonate cannot be absorbed, and alternatively for this reabsorption we need carbonic anhydrase enzyme. Okay, so these two things are important for bicarbonate reabsorption by the renal tubules. One is sodium H plus antipode and the other one is carbonic anhydrase enzyme. So when these two are defective, that means in renal tubular acidosis, proximal renal tubular acidosis, and in patients taking carbonic anhydrase inhibitors, so the reabsorption of bicarbonate will be grossly affected and it can lead to loss of bicarbonate and ultimately normal anion gap acidosis. So that's it about the various causes for metabolic acidosis. Okay, so metabolic acidosis means it can be due to excess acids or due to loss of bicarbonate. If it is due to excess acid, we call it as high anion gap metabolic acidosis, because organic acid is one of the component of anion gap. Okay, if it is due to bicarbonate loss, then we call it as normal anion gap acidosis. Okay, so first for the excess acids, it can be due to decreased excretion or increased production, whereas for loss of bicarbonate, it can be due to loss through GIT or loss through kidney. Okay, so that's it about the causes for metabolic acidosis. Next, we will move on to metabolic alkalosis. Okay, so metabolic alkalosis means just the reverse. Okay, so here also the problem is with the kidney regulation, but what happens is in acidosis, what is happening? There is excess acid or loss of bicarbonate, whereas in alkalosis it is just the reverse, either loss of acid or excess bicarbonate. These are the two major reasons for metabolic alkalosis. Okay, so now we will see the various causes for loss of H plus ions. So this H plus ions can be lost from our body again through two different routes. One is through the GIT and the other one is through the kidney. So first we will see how it is lost through the GIT. Okay, so I said the lower half of the GIT is alkaline. So from there bicarbonate will be lost, whereas the upper GIT is mainly acidic. So from upper GIT disorders, especially in vomiting or in patients who are having nasogastric suction, so there will be loss of H plus acids from their body. Okay, next coming to the kidney. So in kidney, the main loss of H plus ion is through the aldosterone dependent transporter, which is present in the collecting duct. So what is the function of this transporter? Means in the presence of aldosterone, it will reabsorb the sodium ions, and for every sodium ion reabsorbed, it will either excrete a potassium ions or a H plus ions. Okay, so this is one of the major route by which H plus ions will be excreted by the kidney. Okay, so when this excretion increases, okay, when this excretion of H plus increases, then it can lead to metabolic alkalosis. Okay, so when it can increase means whenever there is excess production of aldosterone or cortisol. Okay, so both of these things will be having a same effect in the collecting duct. Okay, so they will be increasing the expression of the sodium channels. The aldosterone dependent sodium channels will be increased, so more sodium will be reabsorbed, and for every sodium reabsorbed, there will be loss of H plus ions, leading to metabolic alkalosis. Okay, alternatively, it can also happen in patients who are taking diuretics. Okay, so diuretics, we have many different types of diuretics. For example, loop diuretics is there, which will act on Henle's loop. We also have thiazide diuretics, which acts on the distal convoluted tubule. So when you take these diuretics, the reabsorption of sodium in the proximal part of the nephron will be affected. So what will happen? More and more sodium will be reaching the collecting duct. So when more and more sodium reaches the collecting duct, more will be reabsorbed. In turn, more H plus will be thrown out into the urine. Okay, so thus excess usage of diuretics can also lead to metabolic alkalosis. Okay, then finally the last cause is hypokalemia. I said sodium, the aldosterone dependent transporter main function is it will reabsorb sodium and in turn it excretes either potassium or H plus. Okay, suppose if a patient is suffering from hypokalemia, what will happen? He will not be having any potassium to be excreted, so more and more of H plus ions will be excreted, and it can also lead to metabolic alkalosis. Okay, so these are the various causes of acid loss from our body leading to metabolic alkalosis. Okay, on the other hand, alkalosis can also be due to excess bicarbonate level in the blood, so which can happen because of the exogenous administration of bicarbonate, either through intravenous or orally. Also, when you take a lot of antacids, okay, in the form of milk of magnesia or something like the Gelusil, Digene, all those things, it can lead to a condition called as milk alkali syndrome. Okay, so that's it about the causes for metabolic alkalosis. So next we move on to the respiratory components, respiratory disorders, respiratory acidosis and respiratory alkalosis. So first we'll start with acidosis. Okay, so what is respiratory acidosis? It is increased accumulation of carbonic acid. So when this carbonic acid will accumulate, whenever breathing decreases, carbon dioxide will accumulate, that will dissolve in water to form carbonic acid. Okay, so this decreased breathing or hypoventilation can happen because of two different reasons. One is either due to the defect in the central nervous system, central respiratory center, or it is due to the peripheral lungs. Okay, so either it can be due to the respiratory center and the defect in the respiratory center, or due to the defect in the lungs. Okay, so the major causes for central, that means respiratory center is affected, when it will be affected means when a patient is on narcotics or barbiturates, alcohol, or in CNS trauma, tumor, infections and CVA. In all these conditions, respiratory center will be suppressed. Okay, so when it is suppressed, what will happen? It cannot send signal to the lungs, so hypoventilation will happen, carbon dioxide cannot be excreted, so it will accumulate and it can lead to respiratory acidosis. Okay, alternatively, it can also happen with all the lung disorders where the ventilation, the breathing or ventilation is grossly affected. So this includes COPD, chronic obstructive pulmonary disease, pneumonia, pulmonary edema, hydro or pneumothorax, status asthmaticus, kyphoscoliosis, and even morbid obesity. Okay, so that can also affect the relaxation of the diaphragm, and it can also reduce the ventilation process. Okay, so all these things leads to accumulation of carbon dioxide, carbonic acid formation, and ultimately to respiratory acidosis. On the other hand, respiratory alkalosis can happen because of hyperventilation. Okay, acidosis is due to hypoventilation, due to accumulation of carbon dioxide, whereas alkalosis is due to hyperventilation. More carbon dioxide will be washed out from the body, and thus it can lead to respiratory alkalosis. Okay, so this alkalosis or carbon dioxide washout or hyperventilation can happen in following conditions. So when a patient is in anxiety or in suffering from hysteria, head injury, fever, gram-negative sepsis, salicylate poisoning, hypoxia, and patients on artificial ventilator, and even hyperthyroid patients. Okay, so in all these patients, the respiratory center may be stimulated, so it may lead to hyperventilation, excess washout of carbon dioxide, and ultimately leading to respiratory alkalosis. Okay, so these are the various causes for respiratory alkalosis. Okay, so before winding up, I would like to give you one small clinical significance. Actually, this salicylate poisoning, we saw it under the causes for metabolic acidosis also and respiratory alkalosis also. Yes, it can produce a mixed type of disorder affecting both the respiratory component and also the metabolic component. Okay, so how it will affect both the components means salicylate poisoning, salicylic acid, when you take as such, it has a capacity to stimulate the respiratory center, and it can lead to hyperventilation, ultimately leading to respiratory alkalosis. Okay, so initially when you consume excess salicylic acid, it can lead to respiratory alkalosis. But after some time, when that salicylic acid gets metabolized in our body, it leads to oxalic acid formation, which in turn can ultimately land up to metabolic acidosis. Okay, so patients who are on salicylate poisoning, initially they will be having respiratory alkalosis, for then they will be followed by metabolic acidosis. Okay, here this metabolic acidosis is not a compensatory effect. It is actually a mixed disorder where both the components are affected. Okay, so that's it about the causes for various acid-base disorders. In the next video, we will see how to diagnose all these acid-base disorders. Thank you.